Welcome to Question Healthcare, investigative podcasting in ethics, health policy, and health humanities. I'm your host, Christy Rentmeester. Our guest is Olivia Kates from the Berman Institute of Bioethics and the Division of Infectious Diseases at the Johns Hopkins School of Medicine in Baltimore, Maryland. Welcome, Olivia. Good to see you again.
Hi, Christy. It's great to see you again. This sounds really exciting. Looking forward to being part of the project.
Dr. Kates shares a case with us that draws our attention to ethics questions at the intersection of infectious disease and solid organ transplantation. This is a case involving a patient in their late 20s who has an HIV infection and has end-stage liver disease. Without a transplanted liver, they have perhaps days or a few weeks to live. And one clinical complexity from the HIV infection for this patient is that their lungs are infected with mold. And this diminishes the likelihood of this patient's successful post-transplant recovery. So, to be clear here about the stakes, this patient will certainly die without a liver transplant, and this patient might die despite a liver transplant. Now, in some sense, that can be said of any patient who needs a scarce whole organ, but we need to put that up front there because it really frames the rest of the ethics questions that we will discuss. So first, Olivia, what should our listeners know about different kinds of liver transplants? There are lobes of livers, there's whole livers, there are other kinds. Help us get a lay of the liver transplantation land here, Olivia.
Yeah, so I'm an infectious diseases doctor, but I work with immunocompromised patients, so especially patients who are either getting or have received an organ transplant. And this is a really typical question for us, a patient with an infection who also needs a transplant. There are a couple of options for liver transplantation. Some patients can have a living donor liver transplant, where a donor gives a segment of their liver, usually it's the right half, and that's transplanted to the recipient. And for both patients, the donor and the recipient, the liver regenerates to its previous or healthy typical size. We give the bigger half actually to the recipient because they need more liver to start out with. We leave the left lobe with the donor. Both patients are expected to have a pretty good recovery. The advantage of living donor is you get your transplant sooner, right? Because deceased donor liver transplants are allocated in what is basically a sickest first sequence. And so the patients who are eligible to receive these and likely to have a match in the system are the sickest patients of all. If you wait until you are one of the sickest patients of all, then you can get a deceased donor transplant, living donor transplants. If it's someone who's directing their donation to you, you may not have to be that sick or wait that long. The livers from either donor type are actually often quite healthy because you get a smaller piece from the living donor that might offset any difference in the health or quality of an organ that you get from someone who you can easily assess and be sure of their health before they donate. So really the only advantage is time.
Let's talk about the criteria here that are used to evaluate which patients get livers and when and why. So the nation's organ procurement and transplantation network prioritizes patients who are the sickest. But the patient's likelihood of successful recovery is also key. And this balance between being the sickest and also the most likely to survive the transplant and recover well seem hard to strike, even in cases that do not involve an infectious disease. So help our listeners understand that tension.
Yeah, that is completely true. And it's a reminder that transplant is not a single decision. There are many different decision points along the pathway to a successful transplant. Some of them are even earlier than we've talked about, things like recognizing end-stage organ disease and referring patients to a transplant center. But the two key decisions that you're talking about are candidate selection, which happens at the transplant center. Our liver transplant program leadership and consultants give advice on which patients would be good candidates to receive a liver transplant. And that's where we think about things like whether the patient is too sick to transplant. And selection is kind of a black and white decision. ultimately either the panel agrees to move forward with listing the patient as a candidate for a liver transplant, or they agree that they're not going to do that, whether they're not going to do it today or potentially think the patient is not now and will not ever be a good candidate for a liver transplant. That's selection. Allocation is overseen by the Organ Procurement and Transplantation Network, the OPTN, or UNOS. It is a public-private contract held by UNOS currently. And allocation is this sort of algorithmic process by which we determine when an organ becomes available, which candidate is going to get it. In liver transplantation, allocation, like I said, is sort of a sickest first equation. They use a score called the MELD score, Model for End-Stage Liver Disease score, and allocate organs to patients with the highest scores. There are a few other factors that go into the algorithm, but the probability of survival after transplant is actually not one of them. That's the responsibility of the selection committee to consider when they're deciding who to put on the list in the first place.
Right. And just for our listeners, UNOS is United Network for Organ Sharing. Right. So, Olivia, you mentioned the role that region plays in organ allocation, particularly organs that have to be transported, some whole organs or organ parts, perhaps, transport better than others. Tell us a little bit about that, how that plays out.
Oh, yeah, that's right. So not only is it important to have a candidate in need of the organ as it becomes available, which again is usually true for organs, but for donors who test positive for HIV may not be the case. They have to be within sort of striking distance. And the allocation policy takes this into account as well. So they allocate organs somewhat preferentially to closer rather than farther away candidates. How they do that changes over time. Used to be region specific. Now some organs go by continuous distribution based on nautical miles, although very few of them are traversing any actual sea. And it has implications, right, for the sort of health and quality of the organ by the time it arrives to the recipient candidate. Some of those implications are changing with innovations in things like machine perfusion or transporting the organs on pumps. It also has interesting implications for the environment. We use aircraft often to transport these organs for sort of the health and just general fatigue and misery of the transplant teams, some of whom travel in these aircraft to procure organs and then bring them back to the recipients in their area. So there are a lot of different factors that go into making this machinery of transplant allocation work around the country. Many of them are changing actually right now, so I'm excited to see the future of geographic differences in transplantation.
So now let's look a little bit more closely at how this patient's HIV seropositivity matters in this case. So first, one key thing here is that a candidate with HIV can agree to accept a liver from a deceased donor who also had HIV, and patients who need a liver but do not have HIV cannot. So what that means is that when a deceased liver donor tests positive for HIV and there's no actively listed patient with HIV who's eligible to receive that donor's liver, that liver will not be translated into a patient who does not have HIV. In other words, if the liver of a deceased donor with HIV is not transplanted into a patient with HIV, the donor's liver is not donated to anyone. It is discarded. And discarding a liver sounds wasteful, and that's really the part of the crux of this case. So do tell our listeners, Olivia, how you think this through in practice.
Yeah. So I think the history of this is pretty interesting. I think it'll be intuitive to a lot of listeners that historically we didn't do organ transplants from donors who tested positive for HIV because there was a very high likelihood, probably inevitability of transmitting HIV to recipients by doing transplants. A couple of decades ago now, some of those transplants were done under extreme circumstances. A living donor actually donated to their child who was negative for HIV under circumstances where their child otherwise would not have survived. And that very first case kind of opened the door to exploring organ donation from donors who test positive for HIV. It turns out that donation from donors with HIV to recipients with HIV does not seem to result in any increased complications. That fear of transmitting HIV is less relevant because recipients are already positive and getting treatment for HIV anyways. And now we have this sort of second pathway for transplantation that's only open to candidates with HIV because they're the ones who can most safely or with the fewest complications receive organs from these donors. It's really interesting in the liver world because all of liver selection and allocation is really informed by the idea that livers are scarce, right? That we have to be extra thoughtful and careful about how we use them. So we have to select candidates who are likely to survive after transplant. And we have to allocate organs to those candidates who have the most pressing need. For candidates with HIV, there aren't many waiting for liver transplantation, and there are many instances where a donor or a potential donor who tests positive for HIV is not able to become a liver donor because there's no suitable candidate currently on a list that's eligible either in their region or maybe even at all. And so it really changes the ethical considerations when we are trying to figure out whether this potential recipient should be added to the list. So when I see a liver transplant candidate who has an active invasive fungal infection, usually I would say this is not a good candidate for organ transplantation. There's very high likelihood that the transplant would not be successful. And we have a responsibility to try to have as many successful transplants as possible. That responsibility comes from the scarcity. And when the scarcity is not there, we think about the whole endeavor a little bit differently.
So let's revisit this historical context that you brought up, Olivia. So there are so many cases historically in which HIV seropositivity has been a source of unjust bias and marginalization of patients. But this is a case in which HIV seropositivity could be construed as an advantage. Some recent historical context might be helpful here, which you've mentioned, but I'll just kind of put some more points on it here. It was only since 2016 that livers became available to patients with HIV. And since then, some have argued that HIV seropositivity, justly or unjustly, confers this special access, if you will, to a liver that's not available to patients whose likelihood of transplant success is also low, but for reasons other than HIV seropositivity. So, Olivia, help our listeners understand the role of this historical context in thinking through the ethics questions about what might be called a kind of prioritization pathway for patients with HIV who need whole liver transplants.
So, in effect, this has become a little bit of an accelerated transplant opportunity for people living with HIV. It's most noticeable in the kidney transplant population, where candidates with HIV who pursue transplants that include transplants from donors who test positive for HIV have much shorter waiting times for kidney transplant because they're in a smaller pool of candidates. For liver transplantation, it's rare regardless, but rare enough that, of course, the pool of candidates is really small. The historical context, though, was actually completely informed by stigma toward people with HIV and by the experience of disease transmissions, mostly viral hepatitis infections through the blood supply, and early HIV transmission in the blood supply as well. It actually led to a federal law making it illegal to perform organ transplantation in the United States from a donor who tests positive for HIV. And so creating this new transplant program required a new pathway for patients with HIV to seek transplants from donors with HIV. The HOPE Act is what makes it possible for these transplants to happen. And further revisions to the law continue as we open up the same pathway in heart and lung transplantation and as we expand access to hope transplants to outside of the research context. What used to be sort of a stigma or a disadvantage in transplantation, I think historically it was also harder for candidates with HIV to be listed at all because of stigma and bias. There are even instances, I hope remaining in the remote past, of physicians declining to treat or perform surgery on candidates with HIV because of the fear of contracting the virus. Now, I'm pleased to see a 180 on this topic area because this is really meaningful for recipients with HIV and also for people who want to be donors who are living with HIV.
So here's a question that I suspect a few of our listeners might have, and maybe a few of our students, maybe your students have asked this question, Olivia. There's good treatment for HIV now, treatment that keeps a person's viral load so low that it's essentially undetectable. So in which cases might it make sense for some patients waiting for a liver, regardless of HIV serostatus, to receive a liver of an HIV seropositive deceased donor? In other words, get the liver and then you contract HIV and then you treat the HIV. Say more about that.
It's tempting, isn't it, Christy? Peers and colleagues in the transplant profession, many of whom are like, wait a minute, why wouldn't I take a liver from a donor with HIV under that circumstance? Forget the fact that the patient already has it. Why can't everybody have that? But maybe people will be most inspired by the fact that it's the transplant professionals themselves who are eager to say, I want that liver. Go ahead and give it to me. I would take one. We do transmit other infections through transplantation. We do transplants from donors with hepatitis C infection, which is now a curable infection for, I would say 99.9% of people who are infected with hepatitis C can be cured with medications. So we find the curable nature of the infection quite reassuring. But we also transmit incurable infections through transplantation. We transmit cytomegalovirus in a huge proportion of transplants, and CMV establishes latency in the recipient, and they can potentially deal with CMV complications for their entire life. There are medications to control but not eliminate CMV from the body. We also transmit Epstein-Barr virus through transplantation. And for most healthy people, Epstein-Barr virus is not especially dangerous, although it has quite a few unusual clinical associations. In transplant patients, it can cause a type of lymphoma called post-transplant lymphoproliferative disorder, or PTLD. I personally find that a little scarier even than a transplant-transmitted infection like HIV that could be controlled indefinitely with medications. There's a whole group of kidney transplants that are called sort of rescue or kidney after liver, kidney after heart transplants, because so many patients who go through these high stakes vital organ transplants also suffer kidney injury as a consequence of all of the difficult things that they go through. And many of them go on to have a second transplant in order to get off of dialysis.
And that's regardless of their HIV seropositivity.
That's right, regardless of HIV seropositivity. In transplant, we know we are already doing this all the time. Why can't we do it with this particular infection? That's the history of stigma that's still holding us back, I think.
And Olivia, what do you see as some of the most exciting ways in which liver transplantation ethics questions like this and others are being researched right now?
Yeah, I'm very interested in qualitative research and both patient and provider experiences in transplantation. I think a great way to do ethics is to try to elicit and distill people's moral intuitions and sort of moral emotions as they go through these situations in real life. One of the topics that my research team works on is liver transplantation for people with alcohol-related liver disease, which has historically been a very ethically and socially fraught topic. But I find that I learn a lot about the ethical issues just through interviewing and working with the people on the ground. This involves surgeons, hepatologists, psychologists, social workers, ethicists, nurses, everybody who is going through this, along with our patients and their families, has their own take on the ethical issues. They don't always express them as ethical issues, but if you listen, everybody is using their moral intuition or their moral reasoning to figure out how they can be a sort of purpose-driven part of the transplant journey for someone getting their transplant for alcohol-related liver disease. I like hearing from the people.
That's a great insight on how we need this rich plurality of perspectives in order to do ethics well. And obviously, you're right at the cutting edge of so many of these interesting and important questions, Olivia. So thank you to our guest, Dr. Olivia Kates.
Thank you, Christy. It was great being here. I hope we get to chat again.
And thank you, our listeners, for being part of the Question Healthcare community. To learn more about QHC or to share a case or question that you might like us to investigate, go to healthpolicyethics.com. Thank you.